Hey fellow lab rats, this is Rebecca from the Lab Rat YouTube channel. In this video I'm going to be discussing immune hemolytic anemias. Alright, let's get started. So we've been talking a lot about hemolytic anemia. So this is when the red blood cells are prematurely lysing, causing a decreased red blood cell count and hemoglobin level. In immune hemolytic anemias, the lysing of the red blood cells is caused by an immune-mediated process. So an immune-mediated process, so what the heck does that mean? All right, so here we have a red blood cell here, and there are a ton of antigens that are present on the surface of every red blood cell that we have in our body. So these antigens are genetically determined. So in this example, I'm going to use this fake antigen called XYZ antigen. All right, so this XYZ antigen is hanging out on every red blood cell surface. So now an antibody towards the XYZ antigen forms. So here comes that antibody. It's anti-XYZ, meaning it is directed towards XYZ antigens. So it's only going to bind or sensitize to that XYZ antigen. And this binding is going to cause agglutination of that red blood cell. And this is going to be happening to tons of these red blood cells in the bloodstream, causing them all to start lysing or breaking open. So this is what immune hemolytic anemia is, because an antigen-antibody reaction is causing it. Now, when we talk about immune hemolytic anemias and differentiate between them, it is why that antibody forms. So what caused the antibody towards, in this case, this XYZ antigen to form? So this is what we're going to be discussing in this lecture. So what are the classifications of immune hemolytic anemia? So there are autoimmune forms of immune hemolytic anemia. So remember, we're looking for the reason why that antibody forms. In autoimmune cases, the body is not getting exposed to a foreign antigen and producing an antibody towards that foreign antigen. In these cases, the body is forming an antibody towards their own antigen. So examples of this are warm autoimmune hemolytic anemia. So this accounts for around 70% of all autoimmune hemolytic anemia cases. And then there is cold autoimmune hemolytic anemia, also called cold agglutinin disease. Now there are also drug-induced immune hemolytic anemias. In these cases, a patient is taking a specific drug that is causing an antibody towards an antigen to develop. And then there is alloimmune hemolytic anemias. In these cases, the patient is exposed to a foreign antigen, so an antigen that they don't have already in their body. They are exposed to it via transfusion or pregnancy. And when I say transfusion, I mean a blood transfusion. So they're getting a donated unit of blood to them. And their body develops an antibody directed towards that foreign antigen. And when they're exposed again to that foreign antigen, that antibody they develop launches an attack on that foreign antigen. So those are the different classifications of immune hemolytic anemias, and I'll discuss each one of these later on here within this presentation. Immune hemolytic anemia is diagnosed by confirming the presence of an antibody and or complement. The patient will also have an increased reticulocyte level, and nucleated red blood cells can also be present within the peripheral blood smear. And this is because the red cells are lysing and the bone marrow is generating as many red blood cells as it can to try to compensate. So it's going to throw out those nucleated red blood cells and reticulocytes from the bone marrow into the peripheral bloodstream. Haptoglobin levels will also be lowered. The reason being there's going to be free hemoglobin in the bloodstream due to the red blood cells lysing, and haptoglobin that is present within the blood will bind to that hemoglobin to form a complex. So there will not be as much free haptoglobin present in the blood. The levels will be decreased. There can also be schistocytes, which are red blood cell fragments, and spherocytes that are present in the peripheral bloodstream. If the antibody that is causing the reaction is an IgM antibody, we can be able to see this with saline agglutination. IgMs typically react at room temperature. That's why you'll see it just with saline. There is a reagent called AHG, or anti-human globulin. This detects if an IgG antibody is causing the reaction that is causing the hemolytic anemia. AHG is used in blood bank laboratories all the time. It's typically green in colored, and it's pictured here on the right-hand side of this slide. So when we use this reagent, it's called a DAT test, or a direct antiglobulin test. DATs will be positive when there is in vivo sensitization occurring. Patients with an autoimmune hemolytic anemia will have a positive DAT result. Another name for the DAT test is the Coombs test. The AHG reagent is frequently called Coombs reagent as well. So this is used to see whether or not there's an IgG antibody or complement present on the patient's red blood cell membrane. We incubate the patient's red cells with this AHG or Coombs reagent, and then we check for agglutination. If agglutination occurs, this is a positive result, meaning that there isn't either IgG or complement bound to the red cell. A positive result suggests that there are autoantibodies. There are a couple of different types of autoimmune hemolytic anemias. These are warm autoimmune hemolytic anemia, cold autoimmune hemolytic anemia, and paroxysmal cold hemoglobinuria. So let's talk about these. So warm autoimmune hemolytic anemia accounts for around 70% of all the autoimmune hemolytic anemias that occur. Most are IgG antibodies reacting at 37 degrees Celsius, which is body temperature, although some can be caused by IgM or IgA antibodies. So these cause extravascular hemolysis. So this is where the hemolysis is occurring outside of the vessel in the spleen. 70% of the warm autoimmune hemolytic anemias are antibodies towards the Rh blood group system. 60% are idiopathic, just happening spontaneously, and are self-limiting, meaning they will go away on their own at some point. Patients that have this can, of course, develop hemolytic anemia, so have a reduction in red blood cells and or hemoglobin level. Erythrophagocytosis can occur in the monocytes, so this is where the monocytes basically eat the red blood cells. The spleen can be moderately enlarged due to all of the red blood cells pooling in there for destruction. The DAT test will be positive, and in fact there will be panagglutination anytime there is an AHG reagent used in these patients. So this concept will likely make more sense once you have taken a blood bank course, but the AHG reagent is used in the antibody screening test, so that and this test is performed on every patient who needs a blood transfusion. And so patients with warm auto complicate that process because everything will show agglutination with the AHG reagent. Even the auto control will be positive. So this is when patient plasma is mixed with their red blood cells in a tube and tested the same way the others will be. So this will also be positive. And this poses kind of an annoying problem for blood bankers because specifically with the antibody screen, we're looking for an alloantibody, meaning an antibody that they've developed towards foreign antigens, so that way we can give them correct blood products that won't cause any type of reaction. And this warm autoantibody panagglutinating everything in the AHG phase masks those reactions. So it's kind of a pain in the butt as a blood banker to deal with warm autos. So we will see normocytic, normochromic red blood cells in the peripheral bloodstream, so normal MCV and normal MCHC indices. A positive DAT, and recall I said there was going to be a panagglutination using the AHG reagent. So this means there's going to be a positive DAT test, and if the patient needs a blood transfusion, they're going to get an antibody screen. And all tubes in the antibody screen are also going to be positive, showing agglutination because the antibody screen uses that AHG reagent. So check out my blood bank lectures on the DAT for more information and details on it. The blood smear of a patient with warm autoimmune hemolytic anemia is going to have anisocytosis, so a variety of sizes of the red blood cells, polychromasia, which is due to an increase of reticulocytes from the marrow trying to compensate for blood loss, spherocytes and schistocytes, and nucleated red blood cells. Cold autoimmune hemolytic anemia is caused by IgM antibodies and do not agglutinate red cells at any greater than 30 degrees Celsius. This is a complement mediated lysis. Patients, when exposed to the cold, can get a chronic hemolytic anemia from this. There's something called Raynaud's syndrome, which causes the fingers and toes to feel numb in response to cold temperatures or stress. And small arteries that supply blood to the skin narrow in this, limiting blood flow to those areas. So this is a hand of somebody that has a Raynaud's syndrome. See how one of those fingers clearly looks like the blood flow has been restricted in it. So this is very characteristic of that syndrome. Patients with cold autoimmune hemolytic anemia will have a positive DAT result. This agglutination is happening when the blood gets colder. So what would you think would happen if this patient had blood work done? So they have their blood drawn into specimen tubes, and those tubes were sent to the laboratory for testing. So after a little while, that blood is going to cool down, right? So it's no longer going to be at body temperature. So this agglutination is going to be happening. In these patients, if they have a CBC result with manual cell differential, you're going to see this happening. The first indication is on the CBC is going to show a reduced red blood cell level, but the key in this is that there will be a super abnormally high MCHC value. Normal MCHC value should be around like 32 to 36 grams per deciliter. In these patients, the MCHC value will be super increased, like over 60. So if you ever see this, that MCHC value is going to be the slam dunk that this is what this is. The manual cell differential requires you to make a smear of blood on the slide. You likely will see agglutination on that slide as well, because of course the blood is cooling down. The way to combat this is to warm the sample up. So warm it to 37 degrees Celsius for around 15 minutes, then immediately rerun it, and that MCHC value will correct and the results will be able to be reported out into the patient's chart. Paroxysmal cold hemoglobinuria is a rare autoimmune form of hemolytic anemia. So this is characterized by acute episodes of massive red cell hemolysis after exposure to cold, including having hemoglobin present in the urine. In children, this is usually found after a viral infection, and in adults, it's usually associated with a non-Hodgkin's lymphoma diagnosis. This is caused by an anti-P antibody, also called the Doneth-Landsteiner antibody. Patients with paroxysmal cold hemoglobinuria will experience chills, fevers, and cramps after they are exposed to cold temperatures. During a hemolytic attack, the blood will experience the same things that all hemolytic anemias are going to show. So reticulocytes are going to increase because the bone marrow is trying to compensate for the red cell loss. And of course, red cells are being lost, so hemoglobin and hematocrit are going to be decreased. Hemoglobin is going to be released from the red cells that are prematurely lysing, so there's going to be an increased free hemoglobin in the bloodstream, and haptoglobin is going to bind to this hemoglobin and form a complex. So haptoglobin levels are going to be decreased because they're all bound to this free hemoglobin, or formerly free hemoglobin. Hemoglobin is broken down into bilirubin, so we will see increased bilirubin levels in the blood. Spherocytes may also be present. I mentioned that anti-P, or that Doneth-Landsteiner antibody, causes the hemolysis of the red cells in paroxysmal cold hemoglobinuria. There is a Doneth-Landsteiner test to look for this. In this test, we incubate this patient's serum with red cells at 4 degrees Celsius. Then it's warmed up to 37 degrees Celsius, which is body temperature. We look for significant hemolysis in the sample to determine if that patient has paroxysmal cold hemoglobinuria. A therapy for this disorder is just a spontaneous recovery. Alloimmune hemolytic anemias are caused by the immunization of an individual with red cell antigens from another individual. So these are not antibodies that are developed towards the patient's own antigens. The patient must be exposed to a foreign antigen of someone else's. So this happens either through a blood transfusion or a pregnancy in order for these antibodies to develop. Patients can develop antibodies towards foreign antigens when exposed via a blood transfusion. Most of these cases are due to a mismatch in ABO compatibility. So for example, if a patient is group A blood type and they are transfused with a group B donor blood, this is going to cause a hemolytic transfusion reaction. The group A patient has naturally occurring anti-B antibodies present in their plasma. When the group B donor blood is transfused into this patient, those naturally occurring anti-B antibodies are going to attack and lyse the group B donor red blood cells. Patients with this have an immediate reaction. They experience chills, fever, chest pain, they go into shock and experience heart failure. So this is a deadly situation. It's a very serious situation. And this is why it is critically important that blood banking is taken seriously. Now, an ABO mismatch is immediate. There are other incompatibility situations in blood bank that can cause a hemolytic transfusion reaction that is delayed. So an example of this would be a transfusion reaction involving something called a KID antibody. You'll learn a lot about this in blood banking lectures. But if a patient does not have a specific KID antigen present on the red blood cells, and they are given a blood donation that has that specific KID antigen on their red blood cells, the patient that is getting that donated unit can develop an antibody towards that foreign KID antigen. And if they are ever exposed to that specific KID antigen again, when they have another blood transfusion, they can have a hemolytic transfusion reaction. So KIDs are notorious for having a delayed reaction. And when I'm saying KID, I'm not saying KID as like in a child. I'm saying KID, like that's the name of the antigen. It's KIDD. So this isn't going to be an immediate thing. It will be days or weeks after the transfusion of the donor blood that has the antigen in it. Patients will experience jaundice and anemia from it, and their hemoglobin and hematocrit levels will not correct. So patients that get donor blood, they have low hemoglobin and hematocrit, and that's why they're getting the donor blood. So after a transfusion, normally their H&H would increase. So not in this case. There will be no increase of hemoglobin and hematocrit because those donated red cells are lysing. The DAT test will be positive, and that's because there is an in vivo sensitization happening. The patient's antibodies are agglutinating with that corresponding antigen inside their bloodstream. There is a way that we can prevent this from happening, and we do that in blood bank by performing an antibody screen on all patients who are getting a blood transfusion. That antibody screen would pick up on any antibodies that the patient would have. So in this particular case with the KID antigen and antibodies, we would identify that the patient has a specific KID antibody and make sure to give that patient donor blood that was negative for that corresponding KID antigen. Again, blood banking, super duper important. Hemolytic disease of the newborn is a condition that occurs when there is an incompatibility between the blood types of the mother and baby. It used to most commonly occur due to anti-D antibodies. So what would happen is an Rh negative mother would get pregnant with an Rh positive fetus. And on delivery, that Rh positive blood from the baby would mix with the mother's blood. And the mother would develop an antibody towards that Rh positive status, which is caused by D, big D. So she would develop an anti-D antibody. So this does not pose any risk for that firstborn Rh positive child. Now, if she gets pregnant again with a fetus who is Rh positive, which is D positive, the mother's anti-D would attack the red cells of the fetus, causing a hemolytic anemia in the fetus. This is low incidence now due to something that we call RhoGAM. And RhoGAM is an injection that is given periodically to pregnant women who are Rh negative to prevent that anti-D antibody from forming. Because of the development of RhoGAM, the most common cause of hemolytic disease of the newborn now is due to ABO incompatibilities between the mother and her fetus. So for example, a mother who is group O and a fetus who is group A or group B. The mother is going to have naturally occurring anti-A and anti-B antibodies because her blood group is type O. Those anti-A or anti-B antibodies can attack the group A or group B blood of the fetus, causing the hemolytic anemia. So that is now the most common reason for this, although other antibodies can cause this. So an example of another antibody would be KEL. So KEL is another blood cell antigen. What would happen is a KEL negative mother, meaning a mother that has no KEL antigens present on her red blood cells, would get pregnant with a KEL positive fetus. So on delivery, the Kell-positive blood from the baby would mix with the mother's blood, and the mother would develop an antibody towards that foreign Kell antigen. So she would develop an anti-Kell antibody. So that does not pose any risk for that firstborn Kell-positive child. Now, if she gets pregnant again with a fetus who is Kell-positive, the mother's anti-Kell antibody would attack the red cells of the fetus, causing a hemolytic anemia in the fetus. So this can occur with certain antigens, so Kell, big E antigen, and big C antigen, just as examples. All right, so that concludes my lecture on immune hemolytic anemias. If this lecture helped you out, go ahead and give it a like, and please leave any comments that you may have in the comment section for me. And as always, if you like this channel, go ahead and subscribe to it for more educational laboratory content. All right, until next time.